Good morning, good afternoon, everybody. I'm Dr. Finn, and we have a wonderful presenter today, Dr. Mark Chandy from Canada, talking about cardiovascular effects of cannabis. Before I let Dr. Chandy get going, a few housekeeping things. Please make sure you are on mute. Please put your questions in the Q&A, not necessarily in the chat. And after Dr. Chandy completes his presentation, we will open up to Q&A. But in summary, Dr. Chandy earned his MD and PhD in 2008 at Penn State University. After completing med school, he trained in internal medicine at the University of British Columbia, followed by a cardiology fellowship at the University of Toronto. He also completed a fellowship in echocardiography and enrolled in the clinician scientist training program at the University of Toronto. To learn more about stem cell biology, he trained in induced pluripotent stem cells, disease modeling at Stanford University. His research has been published in Cell and other high-impact journals. He holds patents for his novel discoveries, and as a recently appointed assistant professor at the University of Western Ontario, he is an independent physician scientist using iPSC disease modeling, next-generation sequencing, proteomics, and gene editing to understand the mechanisms of cardiovascular disease. His current research focuses on understanding the pathophysiology of environmental exposures, such as air pollution, e-cigarettes, and cannabis on cardiovascular disease using the human iPSC-derived tissue. His goal of his research is to investigate the effects of the environment on the cardiovascular system, discover biomarkers to risk stratify patients, and discover druggable target genes for cardiovascular disease. So with that, thank you, Dr. Chandy. I'm going to open it up for your wonderful presentation.
Thanks very much for that very kind introduction, Dr. Finn. I'm just going to share my screen, and I hope everyone can see. Today I'm going to talk about the relationship between cannabis and cardiovascular disease. My only disclosure is that I'm an unpaid consultant with Greenstone Biosciences, and Greenstone is a biotech company that's interested in translating discoveries from Stanford and Joe Wu's lab into the clinic. My learning objectives are one, understanding the history of cannabis, the different modalities of using cannabis and possible therapeutic indications, understanding the endocannabinoid system, and exploring adverse effects of cannabis on the cardiovascular system. So first, I'm going to talk a bit about the history of cannabis. So cannabis has been around for hundreds of years, centuries, really, I think it dates back to 2800 BC, where in Asia, cannabis was used for medicinal purposes, also in India as well too. In Victorian times, Queen Victoria's doctor actually used cannabis as well to treat her as a type of Ayurvedic therapy. However, around the turn of the century, the 20th century, people became a bit more concerned about cannabis and people started requiring that it be included in labels so that they could be aware of any potential toxic effects of marijuana or cannabis. And in the 30s, of course, with prohibition, along with alcohol as well as other substance abuse, marijuana was prohibited. And in 1970, it became a Schedule I drug, a controlled substance, and it became very difficult to use. Somewhere between then and the 90s, there was a big shift or a change in how people perceived cannabis. In the 90s, we saw movements to legalize it first for medicinal purposes, both in the US and worldwide. And it became actually legal in several countries, such as Australia and Canada. And here we can see a world map, basically up to date as of 2024, but changing by the week and the month. But Canada, where I currently live right now, cannabis is fully legal both for recreational and medicinal purposes. However, it is illegal in many parts of the world, and the former Soviet Union, Russia, as well as the Eastern Bloc states, for example, it is completely illegal, as well as many countries in Africa. There is a lot of variation to the legalization, decriminalization, nuances of low content of THC or CBD being legal. In the United States, we see that as well. There's a lot of heterogeneity with being legal, fully legal in California as of 2016, and legal in many states, but still illegal in several parts of the US. So with decriminalization or legalization of marijuana, there's been an increase in marijuana or cannabis use. And this is data taken from Dr. Page's paper, which was published in Circulation a few years ago. And so in this great paper, he showed that marijuana use was on the rise relative to other drugs of abuse. And so it's, one thing to speculate that perhaps with legalization, decriminalization, there's a sense that cannabis or marijuana is something that may not be as harmful, and the government has allowed it. So there's actually increased use. And in Canada, where it's completely legal from a recreational as well as a medicinal perception, we have lots of data from Statistics Canada. And so this is taken from the Statistics Canada website. And you can see here that as with alcohol, cannabis consumption increased dramatically during the pandemic. And you can see here there's an increase both in males and females for alcohol use. However, in cannabis, very interestingly, there's increase in both males and females, but much more so in females than males, by 53% actually. And so, cannabis use has changed quite a bit over the years. So, 50 years ago, people may have a joint and smoke it, and they would cultivate it themselves. Now, with legalization and refinement, it's possible to extract THC and vape it. In addition to that, it can be consumed as orals and lozenges, and it can be even consumed topically. And there's quite a few different medicinal marijuana options that are used in the clinic. And there's, of course, the synthetic cannabinoids, which more potently bind onto the CB1 receptor, and that can have basically intensify the neurological effects of cannabis. And so THC content in joints has increased significantly over years, primarily due to cultivation. And so back actually in the 70s and 80s, the average amount of THC in a joint was thought to be 1 to 3%. Over the years, more recently, it can be as high as 12 to 15%. However, with extraction, people can actually vape THC at about 85%. So cannabis is a very interesting plant. It's composed of over 400 different compounds, 100 of them being cannabinoids. And the two most abundant cannabinoids are THC and CBD. So THC provides a psychedelic component of cannabis, and CBD is thought to have an anti-inflammatory effect. However, there are many other different components. And as you can imagine, because it's something that hasn't been very well studied, there are a lot of, putative therapeutic indications. There's CBD, CBDV, CBG, CBC, all these different compounds that are thought to be helpful for, pain, promoting analgesia, sedation, anti-inflammatory, potential bone stimulant, potential, beneficial cardiovascular effects, anti-cancer effects. And so there really hasn't been a lot of study until recently as to whether cannabis might be effective. First, really to understand how cannabis can work in our bodies, we really have to understand the endocannabinoid system, how we're really hardwired for it to work. So the body has an endocannabinoid system that's responsible for learning, mood, satiety, and essentially the body produces these cannabinoids AEA and AG2AG, which can bind onto the CB1 and CB2 receptor, the cannabinoid receptor 1 and cannabinoid receptor 2. There are other potential receptors throughout the body, but these are the two major receptors that we know of. And so, as you can imagine, as Dr. Finn was saying, cannabinoid receptor 1 and cannabinoid receptor 2 are most abundantly expressed in the brain. And so the adverse effects of cannabis, or potential adverse effects of cannabis, are probably more likely to be found in the brain. But it's actually found throughout the body as well too. And so there are CB1, or cannabinoid receptor 1 and cannabinoid receptor 2 receptors throughout the cardiovascular system and predominantly in the vasculature. So the cells that line your vessel are called the endothelial cells, and beneath them are the smooth muscle cells. And the endothelial cells are the first things that see, cannabis when you smoke it. And so they have receptors for CB1 and CB2, as do the smooth muscle cells. And these cells are very important for forming plaques that cause heart attacks and stroke. And so it's thought that when THC, the psychedelic component of marijuana, binds on the CB1, it promotes inflammation and oxidative stress that ultimately leads to atherosclerosis. And CB2, primarily in the immune cells, is thought to promote vascular quiescence, or basically preventing atherosclerosis. So, I'll just briefly touch on some potential therapeutic indications for cannabis. As we all know, medicinal marijuana is something that has been around for several decades. There are synthetic THC, dronabinol, and nabilone, that have been approved by the FDA for treating chemotherapy-induced nausea and vomiting and HIV cachexia. And so this is something that has been around for some time and used for these purposes. In addition, there's a lot of interest in using cannabis for chronic pain, and this is something that really hasn't been studied very rigorously. However, this study from 2015, published, I believe, in JAMA, showed that there was moderate quality evidence to support that cannabinoids could be used for the treatment of chronic pain and spasticity. What was interesting, though, they found there was low quality evidence that cannabinoids could be used for nausea and vomiting due to chemotherapy or HIV. So I think that as we learn more about cannabis, as more people are using it, we're able to study it and find, data to support, these potential therapeutic indications. And it's something that's evolving over time. More recently, there were trials to investigate CBD for pediatric seizure disorders. It was found to be effective in Dravet syndrome, as well as potentially for another pediatric seizure disorder as well too. And Lennox-Gastaut syndrome. And you can see here from this study, also published in the New England Journal of Medicine, they found that there was a reduction in drop seizures as well as total seizures with CBD use. Now I'd like to talk about potential adverse effects of cannabis and on the body before going on to the effects on the cardiovascular system. And so I'm not an expert on the psychiatric effects of marijuana, but there is emerging literature to suggest that marijuana is associated with psychiatric effects. It's associated with psychosis, and from observational and experimental cohorts, recreational marijuana has a very large range, but it has a strong association with psychotic symptoms. Less so for medicinal cannabis, but it also does occur. And with respect to other psychiatric effects of cannabis or marijuana, it is also associated with anxiety disorder. And so we find that people who visit the ED with issues with cannabis use are subsequently more likely to have anxiety disorder. And this is much more common in males. The adjusted hazard ratio is 5.67 for males having anxiety after an ER visit. It's also interesting that there is both short and long-term cognitive impairment associated with marijuana. So in this particular study, I was found that marijuana could affect attention concentration, decision-making, inhibition, impulsivity, working memory, and verbal fluency. And these are both acute and potentially long-term effects. And this is something that's continuing to evolve. And just very briefly to touch on possible effects of marijuana on the reproductive system, THC is apparently associated with decreased fertility. And so in this paper published by one of my colleagues here at Western, Dr. Van an endocrinologist, found that marijuana could decrease sperm counts, may delay or inhibit ovulation, and could contribute to infertility into individuals or couples that have difficulty with fertility. And so, the mechanisms are not clearly understood, but THC could be acting on the endocannabinoid system and disrupting the reproductive cycle and fertility. In terms of the effect on the fetus, they're actually more troubling. So this study from JAMA associates cannabis use with birth risk of low birth weight, small for gestational age, preterm delivery, decreased mean birth weight, lower APGAR scores. So it is concerning the effects on offspring at the time of birth, but also what are the long-term effects of cannabis on these individuals, and are they more prone to having psychiatric issues? Because I mentioned the CB1 receptor is the most abundant G protein coupled receptor in the brain. And then, of course, there's the risk of malignancy in marijuana. And this is something that's very difficult to study because often people consume tobacco with marijuana. And up until recently, people were smoking joints without filters. So there's a lot of tar and particulate matter that could go into the lungs, the head and neck, and throughout the body, really through PM 2.5. So it's really difficult to study this. But there's now emerging literature that suggests that marijuana is associated with testicular germ cancers, including non-seminomas. In addition to that, there's a recent paper that came out showing that cannabis use is associated with head and neck cancers. So lung cancers are confounded by tobacco use, and the results will I guess, come out over time. But it does seem to be worse when people smoke cannabis with tobacco in terms of lung cancer. However, attributing it just to cannabis, that's something that's kind of difficult to study in a clinical in a clinical research model. And then, of course, there are issues with intoxication with marijuana. People, as you know, can become have a cannabis use disorder where they continue to use cannabis even when it's causing physical or psychological harm. And the prevalence is thought to be quite high, affecting approximately 10% of cannabis users worldwide, and it's estimated there's about 200 million of them. So there are potential therapies for it, such as cognitive behavioral therapy, and perhaps using cannabinoid antagonists, but the treatments, I guess, to treat cannabis use disorder are to my knowledge, not very effective from what I've read. But I'm not an expert on the effects of cannabis on addiction or mental health, but there are different and evolving and emerging ways of monitoring cannabis use and intoxication. This is something that can affect the workplace as well as driving. It's very difficult to tell if someone is intoxicated with cannabis. So there are field sobriety tests, but the sensitivity and specificity of these tests are quite low. And measuring the concentration of the blood doesn't necessarily correlate with intoxication. So there are new and evolving ways of measuring cannabis. And so this is one, I thought, neat way of doing it, where you have a breathalyzer for THC from Hound Labs. And it actually correlates quite nicely with the serum concentration of THC, but there's something that needs to be further studied to see if it actually correlates with intoxication. So now I'd like to talk about potential adverse effects of cannabis on the cardiovascular system and the emerging data that's coming out. So this is a great paper from Pal Pasher in his Nature Review of Cardiology, where he very succinctly summarized all of the adverse effects of cannabis. So cannabis can cause heart attacks and strokes. They can cause dissection. They can cause myocarditis, pericarditis. They can cause arrhythmias. They can cause heart failure. So most of the data that Dr. Pasher had accumulated in this great review were from case reports and case studies. And so now there have been more rigorous studies looking at larger populations, likely because of decriminalization and legalization that have increased the usage of cannabis. And so I think it's a bit of a dose and time effect where people are more likely to use it. And in addition to that, the way that we use cannabis with vaping and being able to have higher concentrations. So those two things, just like with COPD or lung cancer, the pack year history, it's a dose versus time thing for cannabis as well too. So with respect to cannabis and the cardiovascular system, as I mentioned before, the cardiovascular system has CB1 and CB2 receptors, and when THC, CB1 agonist, binds to the CB1 receptor, it causes inflammation and oxidative stress that leads to atherosclerosis. And with CB2 agonist binding to the immune cells predominantly in the body, it causes vascular quiescence. And so really to understand the clinical data, I want to talk just a little bit about the basic science data. And I was very fortunate to go to Joseph Wu's lab where I learned about stem cell biology and had the great pleasure of working with two very bright postdocs and clinician scientists, Massa as well as Thomas, the first author on this paper. Basically, we studied marijuana addiction in mouse models, and I'll just very superficially describe the experiments that we did. We had, in that environment, the opportunity to collaborate with, really great individuals, including Manuel Rivas, who's someone who had access to the UK Biobank, and this was essentially a large prospective database of 500,000 individuals who agreed to enroll in the early 2000s, and there are clinical samples taken from these individuals, including blood, urine, saliva, and there's an online questionnaire as well as genotyping. So a very rich biobank, and it was prospectively followed. And so one of the questionnaires that came up was actually cannabis use. And at that time, you have to remember, cannabis was illegal in the UK. So a lot of people may not have wanted to participate, and they may have even, if they participated, not wanted to admit to the fact that they used marijuana. But 150,000 people or so participated in the survey, and about 35,000 said that they did use cannabis, and about 12,000 said that they used it more than once a month. And most very interestingly, when we looked at the rate of MIs, it was about 0.53%, which was much greater than the rate in those who had MIs. And these were premature MIs, people under the age of 50 having a heart attack, which is very young to be having a heart attack. And this was data that was analyzed by a graduate student, Angela Zhang, and she did multivariate linear regression analysis and found that cannabis was a risk factor for cardiovascular disease. Our data wasn't strong enough to say that it was an independent risk factor, but it was a risk factor for developing cardiovascular disease. So we then went on to do some O-link analysis, and we had a great opportunity to work with Edward Lau, who is an expert in proteomics, and there's this new technology called O-link at the time, the new technology for looking at proteins in blood. And essentially, two antibodies could bind onto your protein of interest, say an inflammatory cytokine associated with heart attacks, and amplify using PCR technology. So it's very sensitive and very specific. And I also had a really good fortune of collaborating with Kara Lynch, who's a professor at UCSF, and she was interested in marijuana and doing clinical trials in marijuana. And so she recruited otherwise healthy marijuana users. These are people greater than the age of 21, no cardiovascular disease, no real comorbidities, and they regularly use marijuana. And essentially they came in and they smoked for 10 minutes in a smoking room, which UCSF has, and Kara was able to take blood every 15 minutes for 180 minutes. And so in doing so, she was able to provide blood samples, which we used for the Olink panel at baseline and at 90 minutes. And so what we found very interestingly from the Olink analysis that Edward did was that inflammatory cytokines were elevated. 13 inflammatory cytokines were elevated that were all associated with myocardial infarction acutely at 90 minutes. Actually, all of the cytokines were elevated, but when we did the statistical analysis, only 13 ended up being statistically significant. So this gives us hypothesis that inflammation is associated with atherosclerosis, this common hypothesis in cardiovascular disease, and it appears that cannabis might be causing that too. So we came up with this hypothesis that inflammation, oxidative stress caused by marijuana induce cardiovascular disease. And we're also potentially looking for new potential therapies for cardiovascular disease. And could it be that, cannabinoid receptor 1 or CB1 antagonists could block these effects? And so we took cells and put them in a dish and exposed them to THC without any of the PM 2.5 or any other things, just the THC. It had no effect on the cardiomyocytes, the muscle, the cells that beat, no effect on the fibroblasts, the things that help repair the heart. But on the endothelial cells, if you remember the cells that line your vessel walls, they were very sensitive. And so at 5 micromolar, we could see cell death. So what we asked, what was causing the cell death? And so really to get at this, we wanted to use a new type of technology called induced pluripotent stem cells. And so induced pluripotent stem cells were discovered by Dr. Yamanaka, and he was given a Nobel Prize for this because it was a real game changer. It was just like an embryonic stem cell, but without the ethical concerns. You could take someone's blood and take the white blood cells or a fibroblast, a skin sample, and using a cocktail of factors, convert it into a stem cell. And it was just like the ESC, but it also contained the patient's specific genetic information. And through this process, it would strip away all the epigenetic modifications. And the epigenetic modifications are all the bad things we do in life, like drinking, smoking, or using marijuana. So what you have is essentially like a baby's endothelial cell, or that individual's nascent endothelial cell. And using a variety of factors, we can take those iPSCs and differentiate them into whatever type of cell we want. Because we're a cardiovascular lab, we're interested in cardiovascular cells such as endothelial cells, smooth muscle cells, and cardiomyocytes and fibroblasts. So we took the iPSC-derived endothelial cells from 4 healthy donors, and in the process of making them into iPSCs, removed away all of those potential toxic exposures, and then took the endothelial cells, the cells that line the vasculature. We differentiated the iPSC and endothelial cells and exposed them just to THC. And what we found is that there is inflammation, just like in the primary cells, the endothelial cells that we saw. All of them showed that there is inflammation in them, all 4 lines, all 4 individuals. So then one of the really neat things about iPSCs is you can gene edit. And so we know that THC binds onto the CB1 receptor. So, Thomas is very clever. He found a way where he could knock down the expression of CB1. So it's still there in very low amounts, you can see here, but we knocked down the receptor. And when we expose it to THC in white and gray, there was a big reduction in inflammation. So THC is not only causing inflammation, it's primarily doing it through the CB1 receptor. And then Thomas used a very primitive form of AI to find a new compound, a naturally occurring compound called Genistein. It's derived from soybeans. And what he found was that when we expose these endothelial cells to THC, you can see the cytokines going up. So TNF-alpha, IL-6, IL-8, and they stay up for about 10 days. But when you co-culture with THC and Genistein, this is a compound that blocks the effects of THC and binds to the CB1 receptor. You can see the amount of inflammation is much lower, and it goes down in about 4 to 6 days. We then went on to do some mouse experiments, and essentially we took mice, C57 black mice, and exposed them to vehicle THC, or the combination of THC and Genistein, the compound that essentially blocks the effects of THC. And we did something called a wire myograph. And we validated that our THC model was working. We did intraperitoneal injections or sub-Q injections, and we found that the concentration of THC was around 100 nanograms per mil, which is equivalent to the Cmax dose when somebody smokes a 1 to 3% marijuana joint. And then we went on to do the wire myograph, and we found that in animals treated with THC, you can use serotonin to induce constriction, and acetylcholine causes nitric oxide release and ultimately vasodilatation. However, with THC, you see an impairment of that dilation. So this is called endothelial dysfunction. That's the first thing that happens in the pathway of atherosclerosis. And when we add the CB1 antagonist, Genistein, it actually blocks these effects. And this is looking at inflammation. So again, in blue, we're seeing inflammation with THC, and red and orange, we're seeing a reduction in when we co-treat with CB1 antagonists. Just moving on to other mouse model called an allele receptor knockout. This is a mouse model that forms plaques in its arteries when it's fed a high-fat diet. And when we fed these mice high-fat diet for 12 weeks, we could see that there are plaques forming inside the mouse fed the vehicle in black. However, when we fed them THC in blue, you can see there's a larger plaque that's forming, statistically significant. And these plaques in humans might rupture and cause heart attacks or strokes. However, when we use the CB1 receptor blocker, we can see that we could block the effects of THC. And so this proved in a dish that the THC could cause inflammation, oxidative stress, atherosclerosis that could lead to heart attacks and strokes. And this is just showing how the inflammatory cells would migrate into the vessel wall with THC, and how we could block it with Genistein, the CB1 antagonist. And so we have this model where people use marijuana, and as a result of using marijuana, they have inflammation and atherosclerosis. However, Genistein, a CB1 antagonist, could potentially block that. So there have been a number of papers. Dr. Page reviewed the literature and found many papers associated that found an association between cannabis and cardiovascular disease. And this is a paper from DeFilippis and Deepak Bhatt in Boston. Essentially, they took individuals who were under the age of 50 who were presenting with their index MI, and looked at all-cause death and cardiovascular death. And what they found, very interestingly, compared to those who didn't use cocaine or marijuana, people who used marijuana or cocaine had an increased annual mortality and also increased cardiovascular death if they used marijuana or cocaine compared to those who did not. When we look at all-cause death, the adjusted hazard ratio, this is balancing for cardiovascular risk factors as well as smoking, found that if individual used cocaine or marijuana, their adjusted hazard ratio was approximately 2. If they used marijuana or cocaine, it was also approximately 2 for all-cause death. And similarly for cardiovascular death, is adjusting for cardiovascular risk factors, weight, as well as smoking, they found that cocaine or marijuana was slightly greater than 2. And for each individual one, the adjusted hazard ratio was greater than 2. And this is from 2018. And more recently in 2024, Jeffers et al. Came out with this paper essentially associating the frequency of cannabis use. And so they looked at individuals that presented with coronary heart disease, myocardial infarction, stroke, or the composite, and they looked at how much cannabis they were using in the 30 days preceding presentation. And what they found was that there is this linear association between the amount of cannabis that they used and their odds ratio of having cardiovascular disease. And very interestingly, when they took individuals who did not use tobacco at all, who abstained from tobacco, but used cannabis, they found that the risk of coronary heart disease, MI, or stroke was 1.45, 1.49, 2.16, or the composite 1.77. So very similar to the Philippus data. So I think more exciting, or probably the most exciting, pardon me, is this new data that came out in JACC just last month. And so they are looking at individuals under the age of 50, and these are individuals who are otherwise healthy. I should note that in the Jeffers paper, they also found this association was not just in young people, but also in elderly people and those with risk factors. However, in this particular group with Benjamin Horn, they found that individuals basically were otherwise healthy, had no cardiovascular risk factors, very young individuals, but they had an odds ratio, an adjusted odds ratio of 6 for having a heart attack, 4 of having ischemic stroke, 3 of having all-cause mortality, 2 of heart failure, and approximately 3 of major adverse cardiovascular events. So it appears that when the latest and the most recent sets of data actually shows a higher odds ratio of having cardiovascular events if smoking or vaping marijuana. So there was a very interesting study from Holt from Denmark, and essentially they were looking at medicinal cannabis use. One should realize that medicinal cannabis is primarily oral or in sprays. It's not usually smoked or vaped. And so in this particular group was followed, they found that there was a significant association between cannabis and arrhythmias. Almost a twofold adjusted risk ratio. However, they didn't see the linkage between acute coronary syndrome, probably because the route of administration being different. However, arrhythmias such as atrial fibrillation are associated with stroke. And so this is something that can cause a deleterious effect. And there is a linkage between cannabis and heart failure as well too. There was a poster that was presented at the AHA back in 2024 that showed a link between cannabis use and heart failure, but it was thought to be primarily driven by ischemia. So people have heart attacks and ultimately develop heart failure. However, there is evidence that cannabis can affect the cardiomyocytes and potentially cause inflammation and oxidative stress. That can lead to cardiac dysfunction. In addition, I didn't mention it, usually one starts with the cardiovascular risk factors and then goes into, cardiovascular effects. However, there is basically, I would say equipoise. It's the effects of cannabis on cardiovascular risk factors such as hypertension, diabetes, and dyslipidemia. There is data suggesting that it can worsen them, but it may also actually paradoxically improve them, despite all the adverse effects we're seeing with regards to heart attack, stroke, heart failure, and arrhythmias. How it is that cannabis affects blood pressure, for example, is very controversial. And there are many studies in mouse models and in humans as well too that's associated with a lower level of blood pressure, but there are studies that show that it's associated with higher levels of blood pressure. So this is something that merits more investigation, I would say, as well as the effects on diabetes and cholesterol levels, because classically we're thought that these risk factors are the things that cause cardiovascular disease. And so it's very interesting to try and understand what it is about cannabis. Maybe it's just the direct cellular effects that we see in the lab at the basic science level in the dish and in the mice that are causing these effects, and it might be something independent of these risk factors. And so, I think we're at a point right now where cannabis use is very similar to tobacco use back in the early 20th century. So back then, tobacco was thought to be healthy. It was encouraged. Soldiers used to have it put into their pillbox. Physicians. We've all seen pictures of physicians smoking in the office, and essentially. It was not until several decades later that we began to see the issues with COPD, as well as cancer, as well as cardiovascular disease. And so when it was recognized and there was this association made and education began, then we start to see a slight decline in this rise in adverse events attributed to tobacco smoking. And I think we might be right here with respect to cannabis use. And we have better technology now, I think, and better ways to study it. And there is data from basic science as well as from clinical science that suggests that cannabis will cause adverse events. And I think it's important, to educate people as well as clinicians as to the potential adverse effects so that they can make informed decisions. And so I think that with that, I'd also like to thank my wife, who I share a lab with, and I do my research here in London. We branded our lab the Cardiology and Critical Care Research Program, or CRP, lab at the Robarts Research Institute at Western University. And I'd like to thank everybody for all their attention. This is a picture of my lab, the BSL-2 facility, and the Robarts, as well as my family. And I'd be very happy to take any questions.
Well, Mark, that was wonderful. Thank you.
Well, thank you very much.
We're going to stop recording here soon, and then